What is the criteria for a CEC in Busia?
Probably supporting the governor during campaigns.
Precisely. Now, medicine is like the army. A good army is one that has ranks that are based on a criteria of performance
and merit.
And merit. The moment you mess that one up in the army, you've lost your army. That's exactly what we've done in health in Africa. We've lost that ranking and that respect that comes with the position that you hold and the delivery on that particular position. For 10 years, I led the global program in the World Bank, making sure that this thing works. Because medicine cannot be divided into this is private, this is public. Patients can't be a public patient and a private patient. They are for care. So you give them to best care possible and most affordable. And you do that. The biggest driver of cost in health in Africa is not the private sector. It is the dysfunctionality of the public sector.
How?
If Kenyatta can do renal transplant in the way it should do, nobody would go to Nairobi. And if Nairobi receives few demand patients, they reduce their cost. Because the cost driver is on the other side of Ngong Hills. Did you know that when government instituted the medical equipment scheme, with all its problems, the cost of MRI and all these imagings went down in the private sector? Why? Because there was
enough supply.
Yes, and competition. And it was the same person who's reading this thing on this side who's doing it on the other side. So the moment the public sector starts working for public good, then the private sector becomes a supplement. And as a supplement, you cannot control the cost. But the moment the private sector now is a provider, then the public sector is a supplement. Because right now you only go to the public sector because you can't afford it. You don't go there because you like it. And that's a statement that people are making with their own legs. That I'm in Ngong Road. And I have to decide, do I stand left or turn right? Can we live through the mindset of that patient? This one I go, I know I'm going to be poor, but at least by the end of the day, I'll know what I'm suffering from. This one I go, I know they will not charge me anything, but at the end of the day, I'll not have seen anybody.
And you'll have lost your dignity.
Yes. Those are the choices in health. That if we want to improve healthcare in our continent, we have to walk through the experience of that individual. Unfortunately, the moment you become a professional, you stop being mindful of that journey because you're now sitting there waiting for these people to come. You don't know how long the queue is, but you want to take 3 hours of lunch. You leave these people here, them they woke up at 5 a.m. And they are going back 100 kilometers on a road that must take them home. They cannot afford a night there. But you're having your lunch because it is lunch break. It is there in my calendar, it is lunch break. This is not what we were taught. We were taught that the last patient, if you haven't seen him, you don't leave the seat. So your lunch break is dependent on this seat being empty, not the timetable. No. So these are the simple things that eventually you find that they are mixed with politics, and people don't say they don't know what to do. No, we know what to do. We know what to do.
You've talked about, and we venture into insurance here. You've talked about that if, as a Kenyan or an African, if I have an insurance card, in this case, let's talk about SHA, the Social Health Authority, and so what they're offering, then I become a market. Could you?
You stop being a problem.
Mm-hmm.
You know, I've been, for public disclosure,
Mm-hmm.
I've been involved in the discussion of every social health insurance scheme in the continent. I know them deeply,
Mm-hmm.
whether it's Ghana or yeah.
Mm-hmm.
I was greatly involved in the debates of NHIF. In fact, as chairman of Kenya Medical Association,
Mm-hmm.
I sat on the board of NHIF.
Yeah.
The first chairman of KMA
KMA
to sit on the
in the
board
board of
was me.
NHIF.
And it was fought for. They never wanted KMA there.
Mm-hmm.
The issues here are very, very simple. That the way we have structured the health services in Africa was that it was a favor to a few people who could get there. The colonial system, we are very, very good at working in systems that somebody has created, but we are never good at creating our own so that people come to cooperate. NHIF, fortunately, was one of those pioneer programs that Africa can look up to and say that, yes, something like that. But even NHIF was never started with the intention of covering everybody.
Mm-hmm.
It was the intention of covering senior civil servants who were coming into government in early 60s. Their British counterparts, whom they were replacing, were covered by the British NHIS. So they could go to Nairobi, they could go to Aga Khan, they could go to War Memorial in Nakuru.
In Nakuru.
They could go to Kitale, they could go there. That was paid for. But the guy who's taking over from you could not go there. So this is the beginning then of saying, can we create something so
us.
that even as we are co-workers, they can also come there. So it was initially for just that top cream of civil servants. Then now it moves on to all civil servants. Then it moves on to all people in formal employment. And those steps are, each of them are as important because they're consequential. The last step was going to be what to do with the informal sector. And the informal sector is made up of two subsectors. One is informal able, and they are the richest people in Africa. The richest people in Africa are not people who are in formal employment. Because your salary...
You depend on your salary.
But informal sector, let's not just see it in the Juakali guy who's on the street.
Or a mamamboga,
Yes.
boda boda.
Yeah, look at that whole chain. They are able. Then there's informal sector and able. This is where the indigents come in. So informal sector able should be able to pay.
Yeah.
Informal sector and able, the indigents, will never be able to pay.
Somebody has to pay for them.
Yes. And that is the responsibility of government. So in that journey, it was this group here. Two things. One was, how do we make informal able pay their rightful amount? Because formal, it was based on your salary. Informal, we didn't know. But because we hadn't sorted it out, we decided that we'd make them pay the lowest of NHIF. So it was 500. So even if I were a billionaire in private, informal sector, that
500.
was. So it was a question then of doing the maths and economics and coming up with a way of graduating them so that they pay their bit. Informal sector and able indigents, that is a government responsibility. Anywhere else in the world, let them do it. So this has been the debate that has been there now. If you work in the fields in which I've worked in, there are some cynics in the donor world who always said, probably with some iota of truth, that this thing can't work in Africa, social health insurance. One, it's because these guys are not digital. And you can't run an insurance scheme on manual records.
No.
Number two, you can't trust an African with any pocket of money. None. So if you're going to collect this money and put it there, whether it's a rambe for burial, somebody will put his dirty fingers on it. So don't bother. Now, the digital myth, Kenya helped kill it through M-Pesa. Because all of a sudden they're waking up and say, what? So if some of the most secretive things, secrets of a man or a woman are their money and their health. So if you can, these people can trust this phone to carry their money, could they also trust it to carry their health information? And the answer is yes. Just do it with the same diligence that Safaricom has done that. The moment that diligence goes, trust goes through the window. You know, we can kill Safaricom in one go, just like that. Yeah.
Trust.
Just one rumor, and trust goes, and Safaricom is dead. So that is the lesson that we should have taken. That this thing here, it is not just a political pronouncement, no. Because there's no politician who came and told people, please put your money on the phone. And if they did, nobody would have put the money there. So what makes you think that they'll put their money into this thing when it is their health? It isn't. So the messaging and the messenger
is equally important.
Yes. And we've lost it on that because we want it to be a political thing. So now comes the issue of the history of where we've gone. Remember that Kibaki was supposed to sign the universal thing in law when he came in, when Ngilu was minister.
When Ngilu was the minister.
Nikal was the peer, it was the DMS. And it was passed in parliament.
Yep.
It went to the president didn't sign it. Why? Because the country director of World Bank went there with businessmen who ran insurance. They say, Mr. President, this thing here. And that was the time that we were getting this money to expand education. And the president had to listen. I was sitting in DC. So I know each and everything that happened there. Not that it was bad, it's simply that the interests were different. Okay? So subsequent to that, interestingly, major reforms took place in NHIF. And if I tell you, there is no African country that has received more delegations to learn about social health insurance than Kenya. Receiving. Yeah.
Not the ones they go to benchmark outside.
No. People coming here to look at both the history and how it works. My own program brought in nearly 30 delegations from across Africa, Francophone Africa, Lusophone to that. And the most remarkable thing about it was the IT system. NHIF IT system was regarded as one of the most innovative in terms of claim system and all. And when we brought people here from Nigeria and so on, all these guys in the Agbadas, they didn't believe this. You say this is Africa. It is happening here. Kenyans didn't know that they had this. So we brought them here to come and learn. I brought Ghanaians there because theirs was failing. They had started on this big thing. Was failing. Came here, so that I went and helped them redo that. And the means testing.
Yeah.
Created for Ghana a tablet for means testing.
We take a walk as Professor Khama narrates his experience in Ghana, working with them as they navigated how to develop their social health insurance.
Before you came in, you were telling us a story of when you're in the border of Ghana and Burkina Faso.
You know, we are testing the
means,
gadget for means testing.
yeah.
And there has been 2 means testing methodologies in Africa. The one that we did for Ghana, which you can actually adopt here very, very easily. And Ghana was doing it at a time when connectivity wasn't as good as Kenyans. Here you are everywhere you
Everywhere.
go. And that's why we're going on top of trees to see. Will be there. And then we use that to market to the cell phone operators for Ghana to put masts out there, because we say big business, big data is coming. And big data pays more than these calls.
Yeah.
So the incentive then was now for them to do that, rather than the government coming to say, how do we invest in this? That shouldn't be government investment. And that's where public-private sector comes in. We've not used enough of that for the benefit of Kenyans. But the other one was the Rwandese one. The Rwandese one was mixed with tradition. You see, like here in the village, if we say that 1/3 of our population is indigent, so it is 3 out of 10. So you take a ward, and that ward then is divided into villages or communes. And you tell them that out of each 10 households, give us the 3 that you think are most in need. What we found was that the thing is more accurate than means testing.
Then my last question is on the South Sudan. Okay, the second last. The South Sudan healthcare. What lessons did you pick from there? What worked?
If you have a wish, that God gives you a wish to go to the moon, and you start a new health system there. Nobody has ever tried anything. You go to the moon. Yeah, that's a kind of sense that I had of South Sudan. I went. South Sudan was part of my portfolio. In 2006, that's when you are going to medical school.
Yes.
Yeah. And me, I was being asked, the peace agreement had been signed in Naivasha, General Powell and the others. And South Sudan would go through this transition. So the Northerners would leave. Up to that time, the Northerners controlled only 3 urban areas: Juba, Wau, and Malakal. So they were like garrisons with their army there. The rest of South Sudan was under the rebels, not organized. So there was no health care. So if a lady was in labor, it would be the TBAs with her there. If she walked out and told the men waiting here that there's nothing more I can do, they would pick their jembes and start digging the grave, because they would she'll be dying. So I get this assignment that South Sudan is coming, World Bank wants to support this, and we don't know what to do. So I go to South Sudan on my first trip, fly from Washington. And I meet the minister and doctor colleague who had graduated in University of Khartoum, South Sudanese, but the last 30 years he's been a refugee in Australia. And he's sitting under a tree. So we introduced Dr. So-and-so. She tells me, thank you, my brother. You have come. What do I do? I'm the Minister for Health. There's no office, there's nothing, there's no record, nothing.
Isn't
South
that?
Sudan, they've already decided that they're going to divide it into 10 governorate states, each one with a governor. So where do you start? It's one thing saying you're going to Afia House. There was no Afia House. So I worked with this guy over the next 2 years. Moved him from the tree shed to a tent. From a tent to a container. From a container to a prefab. And from a prefab into the ministry offices. They had no idea what facilities exist, because all facilities that were there were being run by humanitarian NGOs who are getting big money, that we have 50 facilities. Later on, I did a count. Dr. Rai actually walked through those, because we were trying to identify them. These guys were taking money for things that didn't exist.
They're not there.
They were not there. And they say we have all these health workers that we are paying, so they give big money. And they all weekend they were in Nairobi. So to get that moving, start from zero. Who are your human resource? Nobody knew if there was any doctor anywhere. There was one anesthesiologist. That's the only thing I can remember for the whole country.
So, in essence, there are just three of you: the anesthesiologist, the refugee from Australia, and yourself.
Yes, but you have all these international humanitarian NGOs that say we are working. I'm a ref was there in one of that they were training health workers. Big budgets, unbelievable budgets. So, trying to organize that, to cut a long story short, I organized the first South Sudan Health Summit. So you're now bringing every state governor and their minister for health in Juba. We put a tent for them. There was no place where. Then to bring them in, because you see, there was no bank in South Sudan.
Cash business.
There was no telephone. There was no newspaper. There was no radio. So when people talk of tenders, when we started doing tenders, tenders were being placed in newspapers here and in Uganda for South Sudan.
Yeah.
And the tenders would be brought to a tender box where we got a welder to make a big box, steel, with an opening there. So that's where they come and put in their tender. And then the day of opening the tender, the guy comes with everybody there, and akata hiyo chuma. So they say these are the tenders, because we had to go to the World Bank transparency. So when these people came, we leased planes from Wilson to go and get them from their states, because there's no roads. Under that government, they used to come to Juba, and you're given the salaries of your civil servants in cash. So you carry it with your askaris to this place. Nobody knows who these workers are. It's just a figure you've given in cash. So these people, we're going to get them. Some of them, they told us, okay, how can we get you? Oh, there's a mini strip here, a plane can land. You go there and you find there's only cows or there's water. They come back. Anyway, we organized the first one. Some of them minister in one state, Upper Nile, meets a minister in Jonglei state. They were schoolmates 40 years ago. One is had been a refugee in America, one has been in Australia. So there's nobody who knew what Sudan is.
Yes.
You know, even up to now, people don't know the parts of South Sudan that people don't know. They have some plants and some animals that nobody knows. So we organized this thing for the first time. This was like a reunion of sorts to discuss what is it that you people want. Then human resource, getting that, what is the training needs and what is that, who's going to do it. Then state, you know, it's like now we have the counties here.
Counties.
There was not a single 1 foot of tarmac in the whole, even in Juba. Just potholes, worse than this my road here. So now it was to get vehicles for the ministry. So I ordered the first 50 Toyota 4-wheel drives. And it was hell because the American government had put an embargo on Sudan. But they hadn't recognized South Sudan. So when we ordered those things from Toyota, they read that and say, Sudan, we can't. I had to get the country director in Ethiopia, World Bank, who was Japanese, to talk to the head of Toyota there and explain to him that this was a different Sudan.
Yeah. It's a
So
different
those
country.
vehicles they come to Mombasa, then they have to be taken all the way through Uganda. Medicine, the first consignment of medicine that we ordered, come to Mombasa in containers. Then they go there. There's no central medical store. So we had created a cold tent where they would go. So if they're coming in December, Christmas Eve, the company that was transporting those things called me, I'm in Washington, that they've been stopped on the Ugandan border with South Sudan, that the soldiers there don't know about this consignment. What do we do? And we have medicine that it's hot, 40 degrees plus, medicine that would expire if they are not there. So you're in DC. So I called the minister. The minister has gone for Christmas with his family in Australia. Because all of them, their families were left out there. They were coming in here like expatriates. So I tell them, okay, now what do we do? How do I solve that? The Minister for Defense in Uganda, Cyprian Nani, was my student here in gynecology. He never finished. He was doing postgraduate. So I call him, it's Minister for Defense. And he tells me, sir, he still kept calling me, sir, don't worry about that, we'll sort it. So he's the one who sent Ugandan army there to escort those things to Juba. We had to start filing. You know, these things you say, which file number?
Yeah.
There was none. I got somebody from Kenya here to go and start training people on filing. Creating the need for human resource for everything. Computers. The first computers, desktop and laptops, the one who got in there. Initially, JICA came and JICA asked me, what do you think these people need most? I told them computers. They just laughed. They couldn't imagine that people would.
As basic as that.
I said, that's what we need. Yeah. So the South Sudan was a labor of love and passion to create a health system out of nothing. And we created this thing, the hospital started working and everything. And then just after I moved to another portfolio, they start war again. And they broke everything down. They broke everything down.
After all that work.
After all that work. Now, whatever we have in our countries, colonial side, they were bad and everything. But let us not underestimate what they left behind.
Yeah.
Because starting from zero, I think I'm one of the few people who have started a health system from zero.
Yeah.
Zero, real zero.
Zero.
Yeah. And I'm forever grateful for that. Because I don't think that there are many opportunities in the world where you can do that.
No.
So the opportunities to get things done properly, to procure properly, to have a different approach, to train properly from Juba Medical School and all that were there.
Yeah.
But the big problem came because far too many of their leaders had been in Kenya and Uganda. And they've learned that leaders here are not poor people.
They've learned bad manners, in short.
So they came with those bad manners where you steal, and have they not been stealing?
Yeah.
Yeah. So you've seen the opportunity of starting afresh and doing it right, and how difficult it is to do things right because of selfishness. So until this DNA of selfishness is gotten rid of, I'm afraid that this sector will be one of the casualties.
You said we need a new crop of something should take the current crop of leaders out
Yes,
en masse.
because I had the opportunity to work in Ghana, and I've had the opportunity to see and discuss what Jerry Rawlings did in Ghana. You know, there was Jerry Rawlings 1 and Jerry Rawlings 2. One, they gave back the government. Second one, he stayed. And the second one, what he did was that he rounded up all these political leaders, rich people, party, many what, and lined them up on Labadi Beach in Accra and shot all of them. Jerry Rawlings became such a controversial person because there are people who hailed him and there are people who hate him because you killed my father. I worked with both children of those who think that they did the right thing and children of who were left orphans.
Yeah.
And I had a chance to chat with them. And do you know what he says? I had no option. Either we have a new Ghana or leave it in the road. These guys control everything. They control the police. They control the judiciary. They control the banks. They control the businesses.
Everything.
So even if you send the police to arrest them, they can't be arrested. If you take them to court, the case never goes anywhere. Postponement. The judges are all them. So you can go there with all your good intentions.
But
And then when you organize elections, they just reorganize themselves. And they're the ones who are heading the parties. And they're the ones who get back. So what do you do? What would you do? He said, to give these countries a fresh start, let us change the players a little bit and see. And see if they can abide to new rules of this game called soccer. And the more I see what's happening in my country and around the region, the more I'm convinced that as inhuman as it is, as undesirable as it is, the sacrifices that we have to make for a new beginning are much, much more painful than we are willing to contemplate. Because if you look at the COVID billionaires,
yeah.
and I've asked myself, because I sat glued to my television when some of those entrepreneurs were being interviewed by the parliamentary and the Senate. First of all, they look pretty well fed and very confident. And somebody goes there and justifies that God loves me. One morning, I'm just passing by the gate of Kemsa, and something tells me,
Ingia ndani.
And then I go there and I find this thing and the papers there. And I feel it.
And I get.
And within a few days, I have this contract of 30 million. My business was that I was selling flowers. So I've never done anything in health sector. And they say God is great. I'm blessed. I'm blessed. Invoking the name of God. And that was happening at a time when the risks of working with AIDS patients and therefore needing protective gear was at its peak. So not only do they not supply, but they give you fake ones. So what is it that drives that kind of greed? Is it greed? Because I know the greed from the animal side, that if I throw a bone there and there's dogs that come, they fight for it. But they don't kill each other. Once one gets the bone, what
wait.
is this thing that happens? And at the end of it, the MPs shake her hand. And she's happy that she's explained to Kenyans how she got this thing.
But is it because the person interviewing was also part of the whole scam? So it was just for public, playing to the public gallery.
Your guess is as good as mine, but the question is, if the systems of accountability are those so much infested, so where do you go?
There's nowhere. There's nowhere to
So
run.
put yourself then in Jerry Rawlings' position. Accept it that that's a way of life, or say that I took these risks and I really want this thing to change. And there's nobody who can doubt that since then Ghana has been a better place.
It is.
It has been a better place. I'm not prescribing anything for them, but I'm saying that in the depth of our contemplation on how to redeem what must be redeemed, because we cannot go on like this. It's bad for everybody.
Yeah. Needs radical surgery.
It needs radical surgery. And radical surgery is not what anybody wants, but is an essential part of the therapy. So I believe that as part of the healing, there has to be a forum for much deeper discussion of this sector. I predicted those years back that even in Africa, debates on the health sector are going to determine the presidency. I think we have arrived there.
We're there. Yeah. Not almost. We're there.
Yes.
We're there.
We've arrived there.
We're there.
That because this of all the sectors where you can't get away with with lies, it's a health
sector. Yeah.
If you're coughing now and we find you have TB, but we don't tell you the truth, the TB doesn't disappear. It just gets your lungs.
It just eats you and eats you.
And this is a thing that I don't think that our guys know. Because the health sector in the whole of Africa has more contracts, procurement than any other. Remember in the height of HIV/AIDS, one of the countries that I was in my portfolio, we've given money to buy condoms. And they confirmed that the condoms have arrived. And you go to the country and you meet the senior people, they say, tuko sawa. Then something tells you to go to the stores and see have they arrived, and you find something tells you, just ask them to open one of them. And there's hesitation. Then you take a knife and just open. What do you think was in the box?
Nothing.
Nothing.
Maybe other things which had been imported other than condoms?
Cotton.
Cotton.
Something else. Something
Okay.
different.
It was Viagra.
Because somebody has seen a business opportunity.
Big market.
Yeah.
Big market going
is-
like hot cakes.
Tragic.
So you see, when the difference between human beings and other animals is that we have conscience, or we believe we do.
We do. We should have.
Yeah. So that's why a dog will do certain things that a human being won't do. This one, I think the dog is better than us.
Yeah.
In the height of HIV/AIDS, somebody has given you money to help your people. So what's the difference between that and the COVID billionaires?
No difference.
It's the same.
It's the same.
So this is an environment in which you are asking me to explain to you how we make the health system work. And then we start by training. So what do we do in training? We say, oh, we have few health workers. So we start opening these schools.
Numbers.
And we create numbers. And we graduate people who didn't train. Then when we have those numbers that we don't even know, you say there are now so many, now let us get them jobs outside. So that now becomes a metric for successful government.
You're training for another market.
Yes. Now, what makes you think that that market respects you?
It won't.
Yeah. Because if you want to train for that market, get their curriculum. Let them open the schools here and you train. That's what Philippines and Egypt does. So it's not run by your money. It is run by
By their
them.
money.
So you come here, German curriculum, we teach them, they know German, this is their schools, they fund it, go. But there's no way in which you're going to take my money. Bring out these crooked guys, whom I can't even employ here, and tell me that the Germans are so desperate that they're going to allow them to run their ICU.
No way. No way.
So, but why do we make it look like we are solving our problem?
It's the pot. Now we've added some pili-pili.
It has taste.
Kafiri-firi kwa mbali.
It's a painful thing for
Yeah.
us who started with a system that we thought we could grow.
Yeah.
It hasn't happened. We wish the next generation better luck than we've had. We take responsibility for some of the things that should have been done differently. For the fact that as professionals we don't have a backbone will allow anything to happen. It's the same mistake that the Americans right now have with Trump.
Yeah.
And you can see what he's taking to them. Yeah. So I don't know. But one thing I know is that when the health sector is in the hands of honest people who are passionate about what they're doing and do it for the people, then it is the easiest sector to run. Because the sector that you can monitor easily. I'm sick, I'm well. I'm on duty, I'm not on duty.
I've done 10 surgeries.
I've done 10 surgeries, that's it. I have a queue out there, I saw them after 5 o'clock.
Yeah.
They're all gone home. Done. Yeah. Anything beyond that is not health sector, it is something else. And I'm afraid that what we have in Africa at the moment is a shadow of what a health sector should be. Not because we don't have the money, not because we don't have the skill, but that we do not have the backbone to say clearly that that's it. And I always use this. we train our pilots in the Air Force to fly these F whatever it is. And they take a lot of time to train. And then if these people come and we're at war with Somalia, and we give them donkeys to ride on to war because you've been a very well-trained guy, and we don't win the war,
You can't blame the pilot.
surely it can't be. It can't be. And this is exactly what we're doing in this sector. All these young people, well-trained and everything, they come out, and the news is what? They're sleeping on the tarmac in Afia House. Nobody has the courage to come out and sit down with these people and say, yes, we are sorry about this, but this one we can do, this one we cannot do. Yeah. Because people don't want to use science, they don't want to use data. As I've given you the data that we have, we don't have any data on human resource. So you can't say that you cannot employ them. We don't have any data on the quality of treatment, so you can't say that we're giving Germans that. But one thing we know is that our most experienced nurses leave.
Yeah.
They don't go there to be employed as nurses. They go into old people's home, but because it's better money. Yeah. And that's it. They are going, leaving the younger ones here who don't know. That
don't
is
have
a loss
experience.
that you cannot replace. Painful truth.
Is there hope?
There must be hope. There must be hope. If somebody could be resurrected from the dead, there must be hope. There must be hope because the change that we need is not that drastic. It's doable. Yeah. And you'll see that, everybody talks about Rwanda. There's nothing that Rwanda has done which Kenya can't do better. Rwanda uses our skills on virtually everything. It's just leadership.
Yeah.
Yeah. So if we change leadership, if our leaders change to work for this country, then the health sector will work, education sector will work, the roads will be there, and everything will be there. We are a rich country. And for goodness sake, God is an African. God is an African. There is nowhere in the world where you see this sun and this greenery.
Yeah.
Throughout the year. And yet we are importing soya from Ukraine, which is in war. If you come with a project here and you have no workshops and per diem, nobody will listen to you. Even if it is going to save every mother and every child, it will not.
I've seen that.
Yeah. Right now, post-COVID, all the procurement and purchase of ICU oxygen ventilators, 95% of them are no longer working.
What happened?
You see, that was the biggest opportunity for us to improve for once and for all emergency healthcare in this country. None. Because they were never brought to work.
It was entrepreneurship.
Yes.